Hello, my name is Dr. Juliet Pham, and I will be giving a presentation on A Tale of Two Drugs, Dickensian Tragedy of Statin and Genvoya. Statins are one of the most popular medications prescribed worldwide, and the association between statin therapy and muscle-related adverse events are well known. However, the exact mechanism of statin-induced myotoxicity remains poorly understood. The purpose of this case study is to illustrate how drug-drug interactions between these therapies can lead to a variety of adverse consequences and negatively impact patient outcomes. Our case presentation begins with a 59-year-old female with past medical history significant for HIV on Genvoya for 10 years, recent initiation of lovastatin therapy approximately 4 months ago, and daily ingestion of borax for 2 weeks, who presented with progressive ascending weakness for 5 days after a viral gastroenteritis. Patient was admitted for acute muscle weakness of all 4 extremities of unclear etiology with concern for GBS and severe rhabdomyolysis with an elevated CK level of 14,901 upon admission. By day 4, patient had developed acute hypoxic respiratory failure secondary to multiple pulmonary emboli, which can be seen here in figure 1. Patient was initiated on heparin drip, upgraded to the ICU. By day 8, patient was emergently taken to hemodialysis due to worsening rhabdomyolysis, oliguria, and persistent hyperkalemia. Patient was also later intubated after being found obtunded with decreased mentation. By day 15, patient was stable enough to be extubated to BiPAP and downgraded to IMC. However, by day 17, patient quickly escalated from BiPAP need to AVAPS, and patient was initiated and pulsed steroids due to concern for idiopathic inflammatory myopathy. By day 20, patient's hemoglobin dropped from 7.3 to 3.9. And 4 hours later, patient was transfused with 4 units of PRBCs and 4 units of FFP and upgraded to ICU for hemodynamic instability. By day 21, a diagnostic colonoscopy was performed due to concern for ischemic colitis, as you can see here in figure 2. Now, by day 28, steroids have been resumed and psychiatry actually had to be consulted for acute stress disorder with psychosis. By day 29, patient continued to complain of abdominal pain, and a CT abdomen and pelvis with oral and IV contrast, as you can see here in figure 3, was concerning for perforated bowel. Patient was found to have a perforated splenic flexure due to ischemic colitis, as you can see here in figure 4, and patient underwent exploratory laparotomy with segmental colectomy and end colonoscopy. So, by day 31, patient had been upgraded to the SICU for hypovolemic and distributed shock requiring Levophed. Patient was eventually weaned off Levophed, downgraded to the IMC, heparin drip was reinitiated, and patient had protracted ileus and had to be initiated on TPN due to severe protein-calorie malnutrition. By day 60, patient was discharged to SNF with calculated ED risk of 93%. Now, although the exact mechanism of statin-induced myotoxicity remains poorly understood, there is reason to believe that drug-drug interactions between statin and Genvoya can potentiate a spectrum of adverse consequences, such as myopathy, myositis, rhabdomyolysis, and even acute renal failure. Therefore, extreme caution must be taken for any patient with coexisting statin and Genvoya therapy due to increased incidence of increased statin toxicity.